Thanks everyone for joining today's session. You're most welcome to today's meeting. It's great to have you here. And today we'll be discussing strategies for eliminating mother-to-child transmission of hepatitis B. My name is Catherine Freeland, and I'm the Associate Director of Public Health Research at the Hepatitis B Foundation, and I will be taking us through today's session. As a reminder, you will be in listen-only mode throughout the duration of the webinar. If you do have a question, you can always put it in the chat box or the question and answer box, and we'll do our best to get to all questions throughout the duration of the session. Just a bit of housekeeping as well. This session will be recorded and it will be posted within a week to the Hepatitis B Foundation's YouTube page. So it will be publicly available to you all to view at a later date as well. You can see a list here of our speakers that we have. We're very excited to welcome Dr. Philippa Easterbrook, Dr. Wangani Musmara, and Dr. Emmanuel Ola, who will be sharing examples from Malawi, Uganda, and then an overview of the guidelines from the WHO. We're also expecting a story from a patient who is a midwife in Nigeria, who will be sharing her best practice and strategies for working on antenatal care and hepatitis B prevention in Nigeria. We also will hopefully have two storytellers joining us. I think there's some connection issues for those guys, but we'll share one of their stories regardless, because we have created a collection of storytelling videos that I'll be sharing with you as well. So that's a bit of an overview. So following all of that, we'll do a question and A at the conclusion of today's session. But as you have questions throughout the duration of the webinar, please feel free to post them in the box. So just to provide a little bit of context and information on the Hepatitis B Foundation, we are a nonprofit headquartered in the United States, and we're dedicated to improving the quality of life for those that are directly impacted by hepatitis B. And we're also working on the research side, the bench science side, on finding a cure for hepatitis B through the Bloomberg Institute. I've included a list of some of our selected programs, as well as a link to our website at the bottom right-hand screen. So definitely check it out. It's a large array of resources, all things related to hepatitis B that might be helpful to you and your practice. Our programs do include a patient consultation line where people are able to reach out to us directly, or family members directly reach out to us and get information on hepatitis B, information about their recent diagnosis, or connected to resources in their local areas. Our website and social media have ongoing information and updates about hepatitis B and hepatitis Delta, which are translated in multiple languages, including a training hub and resources on learning and engaging and becoming certified in hepatitis B education. We have a patient storytelling program, of which I'll reference on the next slide, in which we work to elevate those lived experiences associated with hepatitis B. We have public health research that works to understand and elevate the impact of hepatitis B, anti-discrimination efforts, as well as really efforts all around about improving education and awareness on hepatitis B. As many of us know, there's a lot of information lagging out there related to hepatitis B, and a lot of myths and misconceptions that we're working towards overcoming collectively. So with that, I'll see if any of our storytellers have joined us on today's session. It doesn't look like they have. So what I would like to do is just to share a story, just to kind of center us in the discussion today, from one of my colleagues who's been a major advocate in the hepatitis space. She was one of our first storytellers globally. So I'm going to share Sylvia's story, and let me just get the audio working for us. Okay, perfect. All right, so this is Sylvia's story.
I discovered I was positive when I was 8 months pregnant. I did my test and I discovered I was positive. So The doctors had to call me and they told me how bad it is if the child doesn't take the vaccine within the first 24 hours of birth. They told us to buy immunoglobulin. So we asked them to look for it, and they said it was not available in the state. So they had to start sourcing for it. They told us you have to go to like Lagos or so, but bringing it from Lagos, it might lose its potency and all. So at the end, the nearest they could get was in Enugu State. So then I was in Kogi State. We had to charter a cab that went to Enugu and they brought it, but somehow it came late, but they administered it. I think it was within 72 hours of birth. My husband, he didn't have the money actually because they told us it was quite expensive. It was like 100K plus, but he had to look for the money and he got the money and we sent because he didn't want his child to go through the same ordeal having the virus. So he had to source for the funds and they got it. And the good thing was she was vaccinated and she also took the Penta 1, 2, and 3 afterwards. It was time for me to have my other baby. Then we're already aware, so we had to look for the vaccine on time. So we got it. When I received the news that was positive, my husband, we had to somehow to keep it discreet. We couldn't tell family members because we were scared of stigmatization and all that. But we had to open up to a few who were in the medical line, who understood. So till now, most of them, they are not aware because we don't want stigmatization and all that. A lot of family and friends are not aware I am positive, of which right now I want to do an advocacy, create awareness, sensitization. That is what I want to do right now, for people to know that if you're positive, you are not less than a human. And I want people to know that for the fact your family or your friend is positive doesn't make that person less of a human. Most times, you don't even know you're positive. So, and these things happen mostly from like delivery, a mother's transfer to their child without even knowing. It's not a plague. We have a life to live and we have to live to the fullest. So being positive doesn't make you less of a human. That's what I want the world to know, the society to know. And we need to create awareness around in Nigeria. I personally want to go into that, to create awareness, to sensitization in general, advocacy. That's what I plan to do.
Great. And of course, we certainly wish that Sylvia could be here to share her story with us in person. But I think we had some connection issues for her. But we're happy that she was able to share her story and give us a little bit of a perspective from some of the challenges that people experience related to prevention of mother to child transmission and the challenges that she experienced with HBIG and trying to access that. So with that, I'd like to now turn it over to Dr. Philippa Easterbrook, who will be talking about the guidelines and she's coming as an infectious disease public health researcher and physician from the World Health Organization, and helped spearhead the guideline effort for the updated hepatitis B guidelines that came out in March. So I'll hand it over to you, Philippa. Thanks so much.
Thank you very much, Catherine, and thanks for organizing this important webinar, and to the Hep B Foundation for their strong support and ongoing activities as we move forward following the launch of the hepatitis B guidelines. So I'm going to very quickly run through the headline messages from these new guidelines. And you see here the two main products, a policy brief and then the full guidelines. And that's 250 pages. Next slide. And these guidelines were launched at the end of March at the Asia Pacific Conference in Kyoto, Japan, and just in time for the cherry blossoms, which erupted the day after the launch of the guidelines. Next slide. And there's been a series of dissemination events since that launch. And this is the first of a topic-specific discussion. And I think that's something we very much want to focus on now, because these guidelines are so rich in their scope, that really, in terms of the implementation and the next steps, it's important to zero in on some of the key topics. This gives you the QR code of all the products on the website, the full guidelines, the policy brief, a Lancet commentary, which I think summarizes very well the key messages from the guidelines, and that's a good one to share with colleagues who want a quick summation. And then also the full annexes that include the reports from all the systematic reviews, the modeling, the values and preferences survey that Hep B Foundation was very involved and led. And next slide, please. And this shows you some of the additional products following the global webinar that we did in mid-May, where there is the webinar recording and the presentation also on the website. So that is now for you all to go on and multiply and disseminate the messages. Next slide, please. So this is a quick summary of where we were before the new guidelines. And the last guidelines were almost 10 years ago in 2015. And this summarizes on the left what the algorithm was for who to treat for hepatitis B. And on the right is a summary of the main messages of the recommendations across the cascade of care, the who to treat, the first line treatment, treatment discontinuation, monitoring for HCC. And then very importantly at the bottom, but this was updated in 2020, the recommendation on the use of antiviral prophylaxis for the prevention of mother-to-child transmission. And highlighted in red were the thresholds where we were considering review for the new guidelines. But before we move on to the new guidelines, just again to look at that algorithm on the left. And the who to treat is shaded in blue. So the main message there was that the majority did not meet eligibility for treatment for their own health. And so the majority were really for deferring treatment and monitoring. Next slide. So what was the imperative and the reason for the updated guidelines, other than it had been some time ago, almost 10 years? I think the recognition that still there remained a major gap in testing and treatment uptake. Only 13% of the 254 million with chronic hepatitis B had been tested, been diagnosed, and 3% treated. That is very little progress over the last 10 years. And there was the perception that the guidelines were complex, and the need, as we've adopted with hepatitis C and HIV, for progressive simplification. The recognition of some important regional differences in the demographics and the epidemiology that needed to be addressed, and the emerging evidence, both for the fact that there was still a significant rate of ongoing new infections through mother-to-child transmission, particularly in sub-Saharan Africa, and that those mother-to-child transmission-acquired infections contribute the vast majority of the chronic infections going forward. And then the major access challenges that relate very much to prevention of mother-to-child transmission, the use of antivirals, with the very limited access to Hep B DNA testing, and the low uptake of birth dose vaccination in sub-Saharan Africa. Next slide. So again, to remind you that the focus in WHO guidelines is low and middle income countries, and our guidelines are used by national program managers as well as frontline clinicians. And we very much adopt the public health approach. That's a simplified and standardized approaches using preferred regimens. Next slide. And we, as part of the guidelines process, commission and undertake a wide range of commissioned projects to generate the evidence base and other supporting data, both systematic reviews, modeling, landscaping evaluations, and importantly, surveys of the community and affected population and healthcare workers for their values and preferences and perspectives on potential guideline recommendations. Next slide. So this is a summary of the main topics that were addressed in these guidelines. And although we're going to focus on the prevention of mother-to-child transmission recommendations, that there is a strong relationship between the who to treat, the first-line treatment, and obviously some of the diagnostic and service delivery issues, which I will touch on very briefly. Next slide. So this is a summary of the recommendations on who to treat. And this was the most seismic change in the recommendations in these new guidelines. So the first key message is that treatment is now recommended for all adults and now adolescents down to 12 years with chronic hepatitis B. And that therefore means both pregnant women and girls, as well as non-pregnant women and girls of reproductive age, being eligible for treatment for their own health. And 4 options to either have evidence of significant fibrosis based on the simple low-cost APRI test, a simple blood test using platelet count, an AST, or transient elastography. And if you have and meet those thresholds, or indeed if there's evidence of cirrhosis, that you are eligible for treatment regardless of any other measures, Hep B DNA or ALT levels. You don't need those to start treatment. Or a Hep B DNA above 2000 and an ALT above the upper limit of normal, or presence of co-infections, family history of liver cancer or cirrhosis, immune suppression, comorbidities such as steatotic liver disease or extrahepatic manifestations. Again, any of these, you meet the eligibility for treatment without any other tests required. And then we preserved a recommendation we had from 2015. In the absence of meeting any of the other criteria and no access to Hep B DNA, the presence of persistently abnormal. Next slide. So the key messages are really the focus on the expansion of the who to treat, the inclusion of all age groups with the adolescents and women of reproductive age, allowing a common entry point for treatment. And really, the fact that many more pregnant and non-pregnant women will be then eligible for being on treatment for their own health, which will also complement the expanded eligibility for antiviral prophylaxis, which I'll come on to in a moment, with the option for continuous treatment postpartum. And the 4 and/or options for meeting treatment eligibility will now capture a much higher proportion of those who are Hep B surface antigen positive being eligible for treatment, more than 50%, compared to 8 or 15% previously. And it's applicable to all settings, whether or not there is ready availability or no access to Hep B DNA. And the majority of Hep B surface antigen positive persons and women will meet the criteria for treatment without the need for a Hep B DNA assay. Next slide. I'm going to really skip over these very quickly, other than to say that the evidence base really showed that the incidence rates of developing liver cancer or cirrhosis or death were very low if your viral load was less than 2,000, and showed that progressive increase you see in the yellow and the blue bar if your viral load was greater than 2,000. Next slide. And when we conducted the systematic review of all treatment studies, it showed that the greatest treatment impact and effectiveness was when you had a higher viral load and ALT levels. And there was very limited evidence at lower viral loads. And if you look at the blue box right at the bottom, and it's a very useful and accessible way to present the information, it's how many people with chronic hepatitis B you would need to treat to prevent 1 case of cirrhosis or 1 case of liver cancer, shown in the last 2 columns, according to those different viral loads. And you can see that you would treat just 14 in the high viral load to prevent 1 case of liver cancer, compared with 59 or 210. Next slide. And so this shows you the algorithm on the right for the new treatment recommendations, where the focus now is that the majority will meet eligibility for treatment. And with the summary below of the monitoring, with the annual monitoring that we're recommending. Next slide. So moving now to the first-line antiviral therapies, we previously recommended tenofovir and entecavir as the preferred regimens. Now we are including the option alternative regimens if tenofovir monotherapy is not available. And that's tenofovir with lamivudine or tenofovir with FTC. And this was largely introduced because of the recognition there is still limited availability of tenofovir monotherapy in many low and middle income countries, whereas dual therapy is available through ART programs and so may expand access. Next slide. So moving now to the prevention of mother-to-child transmission. So previously we had a recommendation that in settings where Hep B DNA or E antigen testing is available in pregnant women with chronic hepatitis B, we recommend prophylaxis with tenofovir in those women with a Hep B DNA greater than 200,000 or a positive E antigen. This is now a strong recommendation, moderate certainty of evidence. But in recognition of the fact that in so many places there was and is no access to Hep B DNA, there is now an additional recommendation, a conditional one based on low certainty of evidence, to have the opportunity to offer tenofovir prophylaxis to all Hep B surface antigen positive pregnant women may be considered. And this is really from second trimester of pregnancy until at least delivery or completion of the infant vaccination series. And in addition, of course, to the 3 doses of Hep B vaccination, including a timely birth dose. On the right, you see the algorithm with the 2 pink boxes capturing the 2 options for using antiviral prophylaxis, either those with a high Hep B DNA if you have access to this, or offering to all. And then the box underneath, very important new aspect of these guidelines, which is that all the mothers need to be assessed for treatment for their own health. And that's a big difference. It's no longer just about preventing mother-to-child transmission. It's addressing the needs of the mother also. Next slide. And in this recommendation, we, of course, have the 2020 systematic review showing the important impact of tenofovir on preventing mother-to-child transmission. Really very significant impact, with no transmissions also in those anyway with a Hep B DNA less than 200,000. But in recognition, as I've mentioned, of the lack of access to the Hep B DNA in many settings, particularly sub-Saharan Africa, while recognizing there have been no studies that have directly compared the clinical impact and feasibility of expanding antiviral prophylaxis to all women versus this Hep B DNA-driven strategy. And so we relied on modeling that had been conducted some months prior to the guidelines, while the modeling showing that universal birth dose, of course, remains the most cost-effective PMTCT intervention, and that universal prophylaxis would only be cost-effective in about 40% of the 106 countries. But nevertheless, the cost effectiveness for countries to consider whether to use a universal or a Hep B DNA-driven approach will very much depend on the cost of Hep B DNA and the cost of treatment. Clearly, with a universal approach, many more will be on treatment, but treatment is available at very low cost, $30 per year in majority of low and middle income settings, and the viral load cost remains very high. So this universal approach is one that is feasible and low cost to implement. Next slide. So I'm going to just skip over the next 2 slides because I need to finish, but it's just to emphasize that there are diagnostic innovations with now us recommending the point of care viral load assays, which can be based in the antenatal clinic setting, and the use of this reflex approach to Hep B DNA testing. Next slide. And then finally, just to mention service delivery. And in our guidelines, we're coming up with some good practice principles and approaches, not really yet in a position to make formal recommendations about specific service delivery models, and the importance of every facility having strategies to promote linkage to care, long-term adherence, retention in care, and the critical importance of community engagement. Next slide. And recognizing at the moment, the majority of hepatitis B services tend to be hospital-based and specialist-based, and we have much work to do over the next few years to change that paradigm and provide more integration in primary care and other options. Next slide. And the recognition that we have also a major challenge with our review of all the studies of low retention in care and lower rates of viral suppression than, for example, we see with HIV. So much work to be done. Next slide. On strategies to embed the very principles and interventions we've adopted in HIV and applying that in the context of hepatitis B. Next slide. And then I think the implementation priorities, scale up of testing and case finding, implementation of these guidelines, adoption nationally, the widespread education awareness raising campaigns, and the Hep B Foundation and other organizations are really spearheading this, training of healthcare workers. Next slide. And to finish, just implementation considerations for PMTCT, the importance of increased coverage of Hep B birth dose vaccination, and the opportunity for this support through Gavi eligible countries, the need for universal triple testing for hepatitis, HIV, and syphilis, increased healthcare worker capacity with some training modules for those healthcare workers in antenatal clinic settings, to support expansion of antiviral prophylaxis. And we need some nimble and simple care pathways so that those in antenatal clinics know how and where to refer on to for long-term care. Next slide. And I think next slide, you'll all be aware of the triple elimination initiative, which dovetails with the kind of Hep B care pathway. Next slide. And some very important research priorities going forward. If we're going to implement universal prophylaxis, we need some good implementation science projects to evaluate and learn lessons from the implementation experience. So last slide, and thanks to the many, many people who contributed to these guidelines and with the systematic reviews and modeling and the 4-day guidelines meeting. Thank you.
Thank you so much, Dr. Easterbrook, for that really insightful presentation, really highlighting PMTCT and really opportunities and challenges for next steps to ensure wider access. Again, we're saving questions for the end, but we already have a few queued up that we're really looking forward to getting to. But I'd like to turn to some country examples, really starting with Dr. Wangani Masmara, who is the lead for the viral hepatitis program in Malawi under the Directorate of HIV, STI, and Viral Hepatitis in the Ministry of Health. And then we'll move into an example from Uganda, from Emmanuel Olal, the Senior Associate at the Clinton Health Access Initiative in Uganda. So I'll start and hand it over with you, Dr. Wangani, and then we'll hand it over to Emmanuel to follow up with an example from Uganda. Over to you.
Thank you very much, Catherine. I hope I'm audible.
Yes, loud and clear.
Great. I've been put under the very difficult task of presenting after Philippa, after such an amazing presentation. So bear with me. I just made mine a bit more succinct, focusing on PMTCT interventions in Malawi. Next slide, please. I just wanted to give you a snapshot of where we've come, how far we've come as a country. When the World Health Alliance endorsed the elimination of hepatitis in 2016, there wasn't much progress up until the rapid assessment by WHO was done in 2017, and then a program was established. Since then, there have been multiple challenges in funding to actually establish a program in Malawi. And we made significant progress, if you see on the orange box there, where you can see that we committed to achieving silver on the path to elimination of HIV, STI, or syphilis rather than hepatitis. And then we approved our birth dose. This was after disseminating our first edition guideline for hepatitis B and C. And as of 2024, we are implementing EMTCT strategies for all 3 diseases, including hepatitis, in over 600 facilities across Malawi. Next slide, please. I'll jump straight into the treatment eligibility on what exactly we recommend. Next slide, please. In Malawi, you might have seen a treatment. You might have seen the treatment eligibility algorithm in the previous presentation that Philippa made that was done by the WHO prior to the release of the 2024 guidelines by WHO. we needed to develop our own eligibility criteria algorithm that can be simplified and used at all levels of healthcare. So we're not only targeting specialists in the tertiary facilities, but we also had to make sure we create an algorithm that is easy to use even for those in the peripheral sites, the lower cadres who might not have had that higher level of education. So as you can see, it's quite straightforward. Green and red, they should know exactly what to do. That color code kind of guides them which way to go. And they would know exactly what to do in each case. So the first stage that we do is we make sure that we ascertain whether the patient is HIV negative or positive. Because if they're positive, then the ART in HIV takes precedence. But in the case of pregnant women, Malawi decided to go for prophylaxis, or so the conditional recommendation that Philippa highlighted in the WHO. We had decided to do that because of our own circumstances in the country. So all pregnant women, as of now in Malawi, once they're found hepatitis B surface antigen positive, are commenced on tenofovir and lamivudine. Next slide, please. So, like I said, the most important thing is to exclude HIV infection. And the treatment or the prophylaxis that is given to the mother is given until 6 weeks postpartum. So the idea is to reduce MTCT, and we decided to stop to reassess the pregnant mom at 6 weeks because of the lack of evidence that permitted us to continue. So unless the pregnant woman is eligible for treatment using the same algorithm that I just presented, then they can continue, or they're halted on treatment. Next slide, please. We created a provision as well in our guideline for HPV DNA, so that if it is available, we can also be able to use it. This was also created because we wanted to use our guideline as a lobbying tool. At the time that we were developing our guideline, a lot of interventions were not available. We only had hepatitis B surface antigen testing and tenofovir and lamivudine. That is all. We never had an HPV DNA. We didn't have an HBe antigen. We didn't have any immunoglobulin tests such as M and G to find out whether the illness is an acute or chronic phase. So we had to come up with a public health approach that is going to be able to work at all facilities. But then we said we still need to be able to create a future-proof document that can be used as a lobbying tool so we can be able to implement and reach the standard of care that we aspire to reach. And one of the most important points was that we should have HPV DNA of more than 200,000, or which is also similar to the positive HBe antigen positive test, must start tenofovir as well. And this is actually going to be a reality for Malawi because we've now found resources within the Global Fund grant to procure cartridges for testing, for HPV DNA testing. These tests are now in country and we will commence next month. So exactly what the guideline was created for, we have managed to push that forward. And again, the rest is similar to what I said. Now, the other interventions that we have in Malawi should be on the next slide, and I'll highlight that quickly. Next slide. Great. So as of now in Malawi, the vaccines that are available to prevent MTCT are the pentavalent vaccine, which has been administered in the country since 2002. But because of the absence of the hepatitis B birth dose at the time of the development of the guideline, we needed to really streamline an intervention that we know will be effective in reducing MTCT, hence the prophylaxis or approach that we're taking. We did add the HPV birth dose vaccine into our guideline to ensure that we reduce transmission from mother to child. And as of now, I'm happy to say that we have endorsed nationally the procurement of the hepatitis B birth dose vaccine, and we should be procuring it through Gavi starting next month. So we've made significant strides there. By the end of the year, we're going to have a full cascade in terms of MTCT. So this would mean prophylaxis with treatment using VDF3DC, the hepatitis B birth dose vaccine, the pentavalent 6, 10, and 14 weeks. And that will be a comprehensive package to ensure that we effectively eliminate hepatitis B transmission from mother to child in Malawi. And finally, the MTCT the MTCT strategy that we have at the end of it is that the child should be tested at 9 months of age to ensure that our interventions have worked. And if negative, then the children are discharged from care. And we enroll in viral hepatitis follow-up if they're positive. I had another slide on management of children, but in cognizant of time, I'm going to focus on the MTCT strategies only. Next slide, please. I want to also highlight how we see the importance of patient education and counseling. The first presentation that Catherine made highlighted some serious points that we are looking to improve on as well as a country, which would be patient education and counseling, increasing awareness, and also engaging the community and also community-based organizations to improve their awareness for services that are offered in facilities across the country. This is an area we're lagging behind because we're mostly focused on the biomedical areas as a start. But moving forward, we're looking to change that. I think this slide just highlights what we'll be doing for children who would find out that their child is positive and what we need to do moving forward. But we created a criteria that would make it, we looked at creating a criteria that would use specialist care to identify and also make a decision to start treatment in children who are 2 years and above in Malawi. When we look at our data, which I'll present later on in the presentation, the numbers of children in Malawi who are hepatitis B positive are getting ever smaller. This is largely due to the effect of the pentavalent vaccine that we rolled out in 2002. So with the few numbers, we will be able to isolate within our health system that central hospitals, meaning the tertiary facilities, can actually make sure that the children are looked after and all the necessary interventions are done at that level for children to receive the care that they need. So if they need a biopsy to be done, then it can be done at tertiary level and the child can be managed using that kind of correspondence. Next slide, please. So in summary, our interventions are that we all women that are hepatitis B surface antigen in Malawi, we offer them TDF3TC. We also have a variant of TDF-FTC, and we continue to the mother continues this until 6 weeks post delivery, and we reassess the mother using the treatment eligibility criteria algorithm. And the child is also given the vaccines at 6, 10, 14 weeks, and hopefully by the end of the year they'll also be getting the birth dose vaccine because Malawi has approved a universal hepatitis B birth dose vaccine, and we will be procuring these vaccines through Gavi. And then we will check the surface antigen test at 9 months. Next slide, please. Excuse me. This is just to give you an idea of the rationale of why we did what we did, why we made the decisions that we did. The antenatal completion rates in Malawi for 4 visits, which have now moved to 5, we've revised our guideline for antenatal care as well, is around 51%. It's very low. Most mothers don't complete the antenatal, and when they come to the maternity, they come in the last when they come in labor. Now, if you don't identify the women early enough, you won't be able to intervene in the absence of a birth dose. So it didn't make sense to not do anything at all except just hope for the pentavalent vaccine to work when there were a number of children that were being born from mothers who were hepatitis B positive, but without the birth dose, there was no intervention. So we decided that once we identify pregnant women, then we'll be able to commence them to prophylax, to create prophylaxis for to prevent MTCT in the most practical and pragmatic way. We also looked at the resources that are available for the hepatitis program. Unlike the HIV program, the hepatitis component is not well funded. So one thing that we did is we have a directorate that is combined. So our directorate is called the Directorate of HIV, STI, and viral hepatitis. So we leverage resources from the Global Fund grant and make sure that all under the umbrella of co-infection, we're able to actually get resources from the GC7 grant and provide some of these resources whilst we're able to improve the service, the quality of care for mothers through the streamlining of the birth dose vaccine. Next slide, please. So just to give you a snapshot of what we're doing as well in terms of how we're collecting our data. we're using technology. We're using what we call ScanForm technology. We're working with a corporation called QED, and we're able to collect data at facilities and take pictures of the data, which is then transcribed into real-time data into our national system. And every day we get updates of how many people have been tested, and it's updated, and this DQAs are done very, very regularly. So I'd just like you to focus on this area here where, on the hepatitis B. That so far we've tested over 800,000 people of hepatitis B, and we have about 742 clinics participating in this initiative. We have a huge number of people being tested for HIV, as you can see, as well as syphilis. But I wanted you to focus mostly on the hepatitis B. Next slide, please. And this is here, this is our geospatial map of all the facilities that are offering. This is the map of Malawi, for those who may not know. This is the whole country. So this is just to show how many facilities. We're at 742 facilities now that are testing and are offering services for HIV, syphilis, and hepatitis B. That would include testing and treatment. Next slide, please. And this graph represents the cumulative hepatitis B test at the first visit for ANC for our mothers. As you can see, in January 1st, 2023, we didn't have much data at the beginning, but we've been able to test more than 500,000 pregnant women, and we have up to just under 8,000 women who are positive as well. So our numbers are quite significant and are growing by the day. Next slide, please. And this shows you as well the test disaggregated by sex. As you can see, we're testing this, as this is a PMTCT focused webinar. I would like to draw your attention to the females. These are the 536 pregnant women that were tested. As you can see, relative to males, we're testing more females than males. Next slide, please. And here, as you can see, we have data from ANC first visit as well. And like I said earlier, it's over 8,000 women that are Hep B positive. Next slide, please. And this is just to show you the age groups in terms of how many people we find in terms of the positives and the total number tested. As you can see, most of this is expected because almost all the women that come through to the ANC are of childbearing age, and we're testing most women between the ages of 15 all the way to 39. But even when you look at the number of positives, it's very faint at the bottom there, but there's a red line that shows the number of positives. There are not that many positives if you compare to the number of tests, but the highest number of positives are still ranging from the age groups of 25 all the way to 39. This is largely because of the effects of the pentavalent vaccine that we started in 2002. Next slide, please. And seeing as we are on the path to elimination, most of our tests are being done at the same time. And I wanted you to appreciate a picture of what it looks like side by side with HIV and hepatitis B. And also you can see that our rural and urban testing is not that much different in terms of the number of tests provided. But this is just showing you the prevalence across the country in terms of the age groups. And as I said earlier, most of the positives are being found in age groups 25 to 29, all the way to 45 to 50. Although our confidence intervals on the 40 to 45, 40 to 50 are quite high because the numbers are fewer, it still goes to show that these are the age groups that are affected mostly by hepatitis B, as well as HIV and syphilis in Malawi. Next slide, please. And this is a geospatial mapping of the prevalence of all three diseases in Malawi. Just for interest's sake, you can see that using our data, we were able to map out that we have a bit of an outbreak of syphilis, we have an outbreak of syphilis in the southern region. But when it comes to hepatitis B, even though the prevalence relative to HIV and syphilis is a bit lower, we were able to see the areas that need most attention. And you can't see it, but on the right side of the Malawi map, there is a massive lake that stretches right across from the north all the way to the bottom here. And where it's white, you can see we can conclude that some of the lakeshore districts have a higher prevalence, and that gives us an area to investigate to find out why that is the case and see what interventions we can create specific for this for the group or for the individuals that are there. But we have various theories of why we think this is going on, including the nomadic population of fishermen that usually live around this area. Next slide, please. So, what are our opportunities? We as Malawi are making the most of the resources that we have to really improve services for hepatitis in the country. We have just concluded the GC6 or the NFM3 grant for Global Fund, and we have commenced the GC7 grant. I was privileged to be part of the grant writing team for the GC7. And we were able to streamline or put in several amount of interventions, integrated interventions with HIV and hepatitis B to ensure that services are available in terms of services for capacity building, that will be training, services for procurement of testing commodities, services for, resources for procurement of treatment, and also exploring how we can expedite other programs within that will affect hepatitis programming, such as the people who use and inject drugs, who have a high prevalence of hepatitis C as well, because the program is not only focusing on hepatitis B, it focuses on hepatitis C. Another opportunity that we've recently come across is the price point for hepatitis C drugs has reduced. And in this case, we'll be able to now procure treatment for hepatitis C in Malawi as well. So the program is growing using the opportunities that are around us. And there's an opportunity that I would like to highlight for other countries who may be in this webinar who are also using Global Fund resources. The fact Global Fund supports the procurement of oral PrEP for HIV, but there is an opportunity with the transitioning to injectable PrEP. There is a high demand for this commodity, and there may be an opportunity to utilize oral PrEP, which is TDF3TC, for people living with hepatitis B using the same resources. And that's exactly what we're doing in Malawi, because we have an opportunity with the transition not only to injectable PrEP, but also the transition from TDF3TC to TDF-FTC, which would give us more commodities for people living with hepatitis B. But with the GC7, there will not be a need to do that necessarily, because we have quantified for people living with hepatitis B in Malawi, and everyone will be able to access treatment free of charge at Malawi government institutions. Next slide, please. So in summary, we've decided Malawi is using a public health approach. Hence, there may be questions around why we do what we do, why we give TDF3TC for all women, all pregnant women. Essentially, it's because we realize the climate that we're in. The resource package for countries is dwindling. Even the Global Fund, the contribution to the Global Fund from PEPFAR and other institutions is reducing. And we need to be cognizant of the fact that government needs to take an initiative in co-financing and improving the quality of care for people living with such ailments. And in that case, we need to figure out things that can be sustainable. We need to figure out interventions that can be sustainable over the long term, and not rely so much on the previous approach. So Malawi uses a public health approach in terms of hepatitis B, and we feel as though our guideline is well enough aligned to the WHO guideline, although we will look to create an addendum that will align better, because if we look at the WHO guideline, it's very flexible. The 2024 guidelines are very flexible, and they factor in all these challenges and all these issues that are met in low middle income countries, with several criteria that you may have seen in Philippa's presentation. We may readjust to that. But as of now, our guidelines are well aligned and they do work. And so far, we're making significant progress. Next slide, please. So I hope you see that's the map of Malawi. I hope it's in your mind and you won't forget it. That means thank you in 3 different languages that we speak in Malawi. Zikomo, Tawonga, Asante. Thank you very much.
Thank you. Thank you so much for that excellent presentation and also the great work that you guys are spearheading in Malawi. It seems like you're really taking advantage of the opportunities that you have and the funding streams and trying to think about sustainability and integration where possible. So really commendable work there, and looking forward to the question and answer session where we can maybe dive a little bit deeper. At this time, I'm going to stop sharing my screen and hand it over to Dr. Emmanuel, who will be sharing some examples from Uganda.
Yes, thanks, Catherine. I'll jump right in. Thanks so much, Dr. Wongani, for sharing the examples from Malawi. It's very impressive. I actually see a lot of similarities with what we are doing in Uganda in terms of trying to simplify the treatment, as well as hello, can you hear me, Catherine?
Yes, you're coming through loud and clear.
Yeah, sure. So yeah, really, I see a lot of parallels between what's in Malawi and part of what we're doing in Uganda. So I will keep my presentation brief, mostly sharing with you from the programmatic lens in terms of the history of hepatitis B PMTCT in Uganda, where we are at the moment and where we will be going. A big part of the algorithms that Dr. Wongani shared in Malawi is actually similar to what we have in Uganda. So just a moment. Yeah, thank you. So Uganda has about 2 million people living with hepatitis. That is based on a survey estimate in 2016 by UFIA, living with hepatitis B, but there is significant variation across geographies and populations, including a high prevalence in pregnant women, that's about 2%. As you can see from the map there is a gradient in terms of variation in the prevalence or burden of hepatitis B in Uganda. You can see the darker green in the northern West Nile and northeast of the country, showing much higher prevalence, and much lower prevalence, as you can see in more of that amber color in the southern region. So the burden in Uganda is way higher in the north and much less in the south. We have an estimated population of about, now based on current census, less than 49 million people, but the overall prevalence of hepatitis B is about 4.3%. About 1.4 to 2% of pregnant women are estimated to be having hepatitis B. This is based on the routine health data, which we collect using DHIS2. In prevalence in children under 5 is about 0.96%. And then among those 0 to 14 years is about 0.6%. We have an annual birth cohort of pregnant women of about 2.2 million people. Notably, also, we have disparities in terms of burden of hepatitis B with the people in the lower wealth quintiles and those with having HIV co-infection having higher burden compared to those from higher wealth quintiles or those without HIV. An estimated about 1,000 people die from hepatitis-related complications in Uganda annually. But importantly, the country has been making progress towards preventing hepatitis B as a public health burden in the country. So I like placing that Uganda's hepatitis B program started around 2002, similar to Malawi, with introduction of the hepatitis B antigen as part of the routine vaccination in children, that's in pentavalent. But the real move started in 2015 when the government introduced hepatitis B vaccination program targeting high-risk groups, initially health workers, and then later the adult population. By then, there was little focus on pregnant women and newborn babies. However, by then there was already discussions and assessments to see whether Uganda could launch a hepatitis B guidelines based on the WHO guidelines that was released around 2015. So in 2019, Uganda launched its first hepatitis B, hepatitis C guidelines, and it had a hepatitis B PMTCT component, which is similar to the algorithm that Dr. Wangani shared. It was based on if a woman was HBV positive, had positive surface antigen during pregnancy, they would then have a viral load test done for them. And if the viral load quantity was above 200,000, they would then be initiated on TDF prophylaxis if available, or TDF and 3TC. So that same year, after releasing the guidelines in 2019 September, Uganda launched the HBV PMTCT program. Initially, it was more or less vertical, but in 2022, the guidelines integrated with HIV syphilis dual elimination program was released, thus moving the country more towards triple elimination. We have had further development since then. In October of that same year, the Ministry of Health made a guideline to start vaccinating babies for hepatitis B at birth. But because we did not have any batches of hepatitis B birth dose, the country opted to vaccinate children with the available adult vaccines, but at half the adult dose. So generally, as you can see, moving towards hepatitis B PMTCT has been an evolution over the years. The initial funding for this program came from public financing from the government of Uganda, but from GC6, which is a Global Fund 6, we started receiving commodities from Global Fund for hepatitis B testing commodities, as well as from PEPFAR. So more in that direction, like I've already mentioned, is that at the moment, we are moving more towards triple elimination. So hepatitis B is now integrated into syphilis, HIV dual elimination. And the financing comes from the government of Uganda, PEPFAR for commodities, as well as Global Fund. In terms of access to hepatitis B related services, they are mostly available from level 3 health facilities and above. All antenatal care facilities are expected to test pregnant women or screen pregnant women for hepatitis B using the surface antigen kits. And then those who are positive, the samples are transported to a central testing facility in the capital city for hepatitis B viral load. Pregnant women who have viral load samples above 200,000 then get initiated at a time point in the second trimester onwards. That's, I think, almost third trimester, from 24 weeks of gestation and above. So in terms of the progress, so since 2019, there's been a gradual increase in access of hepatitis B PMTCT commodities. I wanted to share with you some data, but the DHIS2 system was down yesterday for me to analyze and share with you the trend of how the number of women being screened has increased over time. At the moment, we have about 56% of women getting screened for hepatitis B using Hep B surface antigen. You'll see some brief statistics that I had from previous analysis. But I wanted to share in terms of key lessons, what has enabled the hepatitis B PMTCT in Uganda to grow. I have 5 main lessons to share with you. One is in terms of financing, that diverse financing sources from government of Uganda, from PEPFAR, from Global Fund, has enabled expansion of the program and broadening it across the country. There has also been very strong advocacy from civil society organizations. We have a number of them, for example, the National Organization for People Living with Hepatitis, the Hepatitis Aid organization, and many other CSOs have been having very strong advocacy to the Ministry of Health to expand funding for hepatitis B, PMTCT. Second one is in terms of leadership and governance. There has been strong political leadership within the country, as well as technical leadership and support from the Ministry of Health. Within Uganda, we have two technical working groups that are focused on hepatitis B. One is the hepatitis B technical working group, and then the PMTCT or EMTCT technical working group. Both these are two platforms or technical working groups have members from academia, from EPI, that's Expanded Program for Immunization, from the clinical services, laboratories, AIDS control program, national medical stores, development partners like CHAI, as well as CSOs. And this meet routinely about every quarter to discuss and analyze any gaps within the hepatitis B program and make recommendations on how to address them. The third lesson is in terms of service delivery. Integration has been very key. Integrating hepatitis B PMTCT program into routine maternal and child health platforms like antenatal care and EPI has enhanced services success. We still have gaps, but there are efforts to optimize access to prevention of mother-to-child or elimination of mother-to-child transmission efforts within these platforms. The current guidelines, which is to start TDF prophylaxis at 24 weeks, has been very challenging. If a pregnant woman comes earlier on in the pregnancy, like within the first trimester, and she tests positive hepatitis B, they may not return by the 24 weeks of gestation to be initiated on TDF prophylaxis, as experienced in Malawi, like you heard from Dr. Wangani's example. And so based on the current WHO guidelines, there are discussions in the country to move towards test and initiation of prophylaxis of hepatitis, of TDF or TDF-3TC if available. I believe that there will be a positive uptake of these new guidelines from the Uganda side. The fourth lesson is in terms of the health information systems. We use two data platforms to capture data and track treatment of people on who test positive hepatitis B. So we have DHIS2 and we have the laboratory information systems, but the data is in aggregate form, and so we are not able to link the patient who tests positive as to whether they actually completed the care continuum at the moment. Much as we are able to see in terms of numbers, those who have received treatment, those who test positive, those who are eligible for treatment. And then in terms of commodities, whereas commodities are often available, we also have stockouts, and that affects our service delivery. So in terms of my last slide, I mentioned here a few challenges that we still have in Uganda. Despite the positive trend we are seeing, is that one is that hepatitis B PMTCT still lags behind HIV and syphilis programs within the maternal child healthcare platforms. As we can see that as a percent of women who attend antenatal care at least once, only 56% are screened for hepatitis B. This is as compared to almost 99% for HIV and over 80% for syphilis. And so there's need to optimize screening so that more women can get screened for hepatitis B. And we can also see that only about 40% of those who test positive, of the women who test positive, actually get prophylaxis. And at the moment, only 42% of infants are receiving hepatitis B vaccines at birth. This is actually a very significant improvement, much as still below the national target, but it's a very significant improvement from last year, where we were at less than 10%. And then in terms of demand generation, also they still need to grow demand for hepatitis B related services within communities. And then in service delivery, like I mentioned, screening coverage is still low, sometimes for service delivery challenges or stockouts. And then in terms of the M&E systems that are in the country, they are still limited. There's need to disaggregate the data and be able to track each patient across the continuum of care. But I think that with the new guideline updates, we may see more developments towards enhancing access to hepatitis B related services. Thank you so much. Over to you, Catherine.
Thank you so much, Dr. Emmanuel, for that really thorough presentation. Just highlighting some comments that we've seen in the chat box specific to Uganda, really appreciating the connection and collaboration with civil society, and that synergy, I think, is really important. So just want to appreciate and acknowledge that. I think now we will move into the question and answer portion. I think we have about 10 minutes or so for that. So I'd like to start with a question for Dr. Easterbrook. If you could maybe share a bit about the next steps for WHO and how WHO is working to ensure these guidelines are really disseminated and implemented within country levels, and then how might we as civil society groups, as providers, as people in nonprofits, really kind of help facilitate that. So over to you, Dr. Easterbrook, if you don't mind answering that question.
Great. Thanks so much, and for the really excellent presentations from Uganda and Malawi. This is what brings it alive, and the reality check of the challenges and some of the innovations that have already been adopted. Well, I think with these Hep B guidelines, we've had, I think, 6 dissemination events, because I think I've recognized from having done many guidelines in the past that just doing one conference and one launch event is not enough. And recognizing we don't have, in contrast to HIV, which has the International AIDS Society meeting, which is a true global meeting, there's not really a kind of one global meeting. So we've done a number of regional dissemination events in sub-Saharan Africa, in the Asia-Pacific region, the European region, because, you know, hepatitis B with a significant burden on some of the migrant communities is a very important aspect to address there too. And then WHO itself, the regional officers, have also led the regional dissemination events, because they have an outreach into their sort of network. And as I mentioned, we've done the global webinar so that all the materials are on the website and anyone can pick up and run with them. I think the next key step is for countries to adopt and update their guidelines in accordance with the WHO guidelines. And of course, you know, they adapt them. So it's not necessarily a cut and paste in its entirety. And as Wangani has commented on, you know, the need to sort of tweak and revise and nuance them to the local context. And I think what has been very sort of positive news is the number of countries that we now know are moving forward with plans to update their guideline. Either that's ongoing at the moment, or it's planned in the next 6 months to a year. So we need to do everything we can to support that process. And many of these countries have already got national strategic plans, so they have a commitment and an approach. And then these new guidelines will obviously take things to that next level with the simplification. So I think I'll stop there, and maybe we can pick up on, you know, price lowering of prices and access to diagnostics as part of the discussion. Thanks, Catherine. And very importantly, to ask, respond to your final point about what can the sort of civil society and organizations do. Well, I think already there has been a very strong partnership, and that's key both at the headquarters level with the actual sort of main guidelines, and then at the regional level and country level with the kind of support and engagement. So I think, you know, the toolkit that I know is being developed for the use by the community is going to be very important. And now we need to see the same cascading of activity at the country level with these pushing these toolkits being adopted by civil society, working with the Ministry of Health going forward. Thanks.
Thank you. And just a follow-up question as well. We had a couple of questions regarding treatment for co-infection comorbidities, for example. Could you just make a brief comment on where folks may be able to find information on management of hepatitis B and co-infections, comorbidities, that sort of thing?
Is the question more on HIV co-infection, or are we talking about those with metabolic associated steatotic liver disease, diabetes? Yes, what was the angle of that question?
Yeah, so we had one come through on HIV and then another on TB.
Okay, well, just briefly on HIV and clearly, particularly in sub-Saharan Africa, that's a very important co-infection. I think, you know, one of the ironies is that the co-infected patients actually have had better access to care than the mono-infected, because in many, but not all HIV clinics, there was the adoption of kind of routine or more systematic testing, both for hepatitis C and B. And by dint of the fact that the vast majority are on a tenofovir-based regimen, and because they're in care and under supervision and having their HIV viral load monitored and with the sort of the adherence support that is standard, the results have been good in the co-infected population. And we now need to apply that to the mono-infected. I think in terms of comorbidities like diabetes, and we know, and steatotic liver disease, we know that is an additional independent factor that, you know, increases risk of progression. So it's not just treating the hepatitis B that's important, but, you know, if there is diabetes, if there's obesity and alcohol, very important to address the alcohol. And that's all part of our package of interventions. And if you look at the algorithm, it's doing that good initial assessment to identify whether people have got other comorbidities and ensuring there are lifestyle issues that address that.
Thank you. We had a couple of comments, questions regarding the interest in the government buy-in that was demonstrated from Malawi and Ugandan presentations. And I was wondering if you all have, Dr. Wangani and Dr. Manuel, if you have suggestions on tips or strategies that have been effective to really work on getting government buy-in to really take up the charge towards hepatitis B elimination and including PMTCT within that as well. Maybe Dr. Wangani, if you could answer that first, and then we'll give the floor to Dr. Manuel to respond.
Catherine, just to get that clear, you want to know what tips we could have for other countries in terms of leveraging other resources to streamline any kind of interventions? Okay.
Exactly, and getting your government buy-in there. Yeah, thank you.
All right. So I think in my situation, I represent the government. So what we had to do in Malawi is we needed to make our case to the relevant bodies and authorities to say that there is this problem, that if we don't do anything about it, it's going to get worse. Here's the data globally. We need to do ABC. And there are a number of bodies that we need to present to. We have technical working groups at ministerial level that we had to convince. Once we had that, we used our director for our directorate, who has been extremely supportive in terms of all the initiatives for hepatitis B. And thereafter, it was straightforward for Malawi. I think it was very unanimous once we showed that if we don't do something about this problem, it's going to get worse. And what we did also, we used a lot of anecdotal cases from our tertiary facilities where we would have a huge number of patients coming in with advanced liver disease, hepatocellular carcinoma, where we can't do anything about, and it's late because we don't have liver transplant facilities or any kind of advanced medical technology. So we decided to say we want to reduce the amount of deaths that are attributed to hepatocellular carcinoma once we found out that 75% of the hepatocellular carcinoma was caused by hepatitis B. So once we made that case, the government buy-in was good, but they then challenged us to come up with strategic documents, be it which were two. So we have a viral hepatitis implementation framework, and the prevention and management guidelines for hepatitis B in Malawi, which is our first edition. And secondly, we had to make sure that the strategies and the objectives within these documents are aligned to the overall health sector strategic plan for the Ministry of Health. We have our mother document, which we call Health Sector Strategic Plan 3. All the initiatives in our documents were focusing on integration, sustainability, optimization of the health workforce, and improving quality of service care delivery. Once we aligned it to our national mother document, the government buy-in is almost automatic. And thereafter, these are used as a collective lobbying tools to the funding bodies such as Global Fund, PEPFAR, as well as CDC where necessary. I hope that helps. Thank you.
Thank you. Very helpful. Dr. Emmanuel, any tips or strategies that have been effective in Uganda?
I could share some what I think was helpful in Uganda. I see one of the colleagues from CSOs is also online, Emmanuel Lutamaguzi. He could also type in the chats in case he has some additional information to provide. As you can see from Uganda, we didn't start with the documents. So in 2015, when the government started a national vaccination program targeting high-risk groups, we had a kind of outbreak in the country. And so many people were turning up with hepatitis B-related complications. My suspicion is that is what really started prompting government to pay attention to hepatitis B. As you can see, there was a wide time lag between introduction of Hep B into routine vaccination program and 2015, more than 13 years before some attention started being given to hepatitis B. So my suspicion is one that there was an outbreak in northern Uganda, and many patients were turning up with hepatitis B-related complications, either fulminant liver disease, liver cirrhosis, HCC, with hepatocellular carcinoma or liver cancer. And that made government start paying attention to hepatitis B. And even in terms of the program, it's actually started in northern Uganda with a vaccination program in northern Uganda and then in the other regions. But the second aspect I also think is because there were people in academia who had interest in hepatitis B, who could take the lead in terms of shaping the direction of the strategy to be taken up by the government, as well as other members of society who had keen interest, clinicians who had keen interest in hepatitis B. Eventually, of course, the CSOs came in, a number of CSO organizations through advocacy to really go beyond the vaccination and have a national strategic plan that is costed and comprehensive. And I missed that in my presentation, but just in the coming weeks during the World Hepatitis Day, Uganda will be launching its costed hepatitis B strategic plan, as well as an updated guideline adopting some of the recommendations from the current WHO guidelines. And so I think that it's been kind of organic growth in interest within the hepatitis B program. In case my colleagues from Uganda online, they can also type their responses online in the chat section. Thank you.
Thank you. Thank you. And then I think we could go on and really discuss this for an extensive period of time, but just to be mindful of our time. We did have a really great question, I thought, come through the chat regarding challenges associated with home births and also loss to follow-up for pregnant women. I wonder if each of you could share some strategies very quickly on how we can work towards overcoming those, or how you're working towards overcoming those challenges in your regions. Maybe Emmanuel, if you wanted to start briefly, and then we'll pass it over to Wangani.
Yes, thank you, Catherine. Indeed, lost follow-up is a big issue in the cascade of care, as you might have noticed. I want to give one example from a study we are currently doing, a pilot study across the country on point of care viral load testing. What we have observed is that facilities that, for example, have one-stop center or one point at the hospital for comprehensive antenatal care services tended to have more women remain in the cascade of care as compared to those which did not have one-stop center for all antenatal care related services. However, we are thinking also the current guidelines as it is before the updated guidelines were a bit complex. For example, you test someone in first trimester and then you tell them to come 2 months later or a month later for initiation on treatment. Many of our people still reside in rural communities, and so they get lost to follow up. What we are thinking is that, one, we need good counseling, comprehensive counseling in antenatal care, but also we need to simplify the guidelines to possibly start treatment a bit earlier and adopt a much simpler guideline, that is test and initiate prophylaxis. And then maybe we initiate some follow-up activities to see that more women can return for care. The case we are seeing in HIV, when you see in HIV, there's quite higher adherence to treatment as compared to hepatitis B, yet the two viruses are quite similar.
Thank you.
Those are
Thank
brief
you. And I think
examples I
you're
can
right.
share. Thank you. Yeah, over to you.
Yeah, thank you. I think lots of lessons learned from HIV, certainly. So your point is very, very well taken. Thank you so much. Dr. Wangani, any follow-up comments from Malawi and strategies for either home births or loss to follow-up?
So for the home births issue, I can proudly say that in Malawi, as much as it does happen, it's quite the numbers on the lower side. Most of our deliveries, over 90%, are done by skilled birth attendants, which would mean trained healthcare providers. We have small bylaws, even at the village level, that village headmen are entitled to fine women who deliver before arriving at the facility. So this is a thing that's been instituted even in the villages for years. So you'd find that women rather rush to the facilities and deliver on time, even though we do have a number of what we call BBAs, born before arrivals. But our numbers are quite higher than 90% in terms of skilled birth attendant, delivery by skilled birth attendants. As of now, our reproductive health department is engaging the lay cadres in the communities in terms of how we can use them to work with the facilities to provide safe deliveries for mothers within the communities if they're late, rather than them delivering on the way, to kind of cut that gap between the 90 to 90, 95, 98%, so that we can reduce it completely. In terms of the loss to follow-up for hepatitis B, considering our directorate is integrated, what we're doing is we're leveraging the HIV program, or the lessons learned from the HIV program. So as of now, we have a strategy called the Back to Care strategy, or Welcome Back to Care strategy, which looks for patients who are lost to follow-up, who have been on ART and have been lost to follow-up. Now, with those resources, we see no reason not to integrate hepatitis into them, and to find the people living with hepatitis B using those same resources and the same program. We're trying to either integrate our tools or use a separate tool, but use the same modality to find people who are lost to follow-up and learn whatever we can from the HIV program, because this is exactly what they were dealing with in the beginning. And I feel like it would be a miss to reinvent the wheel when we already know how to solve this problem over time. Thank you.
Great. Thank you so much. Totally agree. And I think those are really great innovative strategies that we can think about integrating more widely beyond just Malawi. So thank you so much for sharing those, and looking forward to learning more about those programs as well. Given our time, I just want to take a moment to really appreciate all of our speakers today for sharing their breadth of knowledge. Dr. Philippa Easterbrook, Dr. Emmanuel Ola, and Dr. Wangani Masmara, for really sharing your time and expertise with us today. It was really invaluable, and I look forward to future discussions, really continuing this conversation around strategies for PMTCT elimination. So really appreciate all of you taking your time to be with us today and share your expertise and best practices for your specific examples. I want to draw your attention very briefly to an upcoming webinar. You can view the QR code here for the link to register, but this will be on implementing guidelines looking at antenatal care setting strategies. So following up on this webinar, but really looking more on the diagnostics level and the treatment access level. So I hope that you'll take an opportunity to join this webinar, which will be held on the 17th of July, 9 a.m. Eastern Time, 3 p.m. CET, and 8 p.m. ICT. So I hope you'll take an opportunity to join for that session. I wanted to also thank you as the audience for joining in today's session, for being so interactive and engaged in the conversation. I look forward to connecting with each of you and sharing the recording of today's session with all that registered today. But thanks so much for your time today and joining and your interest. And thanks again to our speakers. Really appreciate everyone being here and everyone's time. With that, I will conclude today's session and hope you all have a great rest of your week. Thank you so much.
Thanks, Catherine. Bye.
Thank you. Bye.